This is part 1 of our lecture series on autism spectrum disorder. In this one, we're going to go through diagnosis and characteristics and impact on family occupations. These are our objectives: to describe the diagnostic criteria, to describe just briefly, some common statistics and prevalence, and to describe the impacts of ASD on individual and family occupations. And we will begin with diagnostic criteria. Autism spectrum disorder is a neurologically based developmental disorder. Individuals may prefer the label autistic or the label person with autism, and it's important to respect the label that they identify with. I love someone with autism who prefers person with autism, so that tends to be my default. Symptoms of autism cluster in two primary categories of functioning. One is social interaction, and the other is repetitive and restrictive behaviors. We are going to go through those in detail. It's important to note that each child with autism presents differently. Autism comes with a diversity of symptoms, level of severity, strengths, and weaknesses. Symptoms are often present from a young age, but diagnosis may come later. It's most common before age 10. Diagnoses made after age 2 are highly reliable, but autism may be diagnosed as early as 18 months. Prior to 18 months, children are receiving developmental monitoring by their caregivers. You may recall the developmental monitoring resources we looked at from CDC that cover milestones. At any point, if caregivers have concerns about missed milestones, that may trigger an evaluation process. In addition to that sort of ongoing developmental monitoring by, say, parents, daycare workers, there's developmental screening, and that's usually by the pediatrician. The American Academy of Pediatrics and the CDC put out recommendations about the timelines on which these things should happen, and these are the most common and most recommended timelines. Do know that this is subject to change as their recommendations change. But right now, developmental screenings by the pediatrician at 9, 18, and 30 months look at overall development and milestones, and there are specific autism screening tools given at 18 and 24 months, and more frequently if a child is high risk. Most commonly, children are identified as high risk when they have a sibling with autism. You might also identify a child as high risk based on previous screening results, right? You may decide to screen more frequently because they were there were a couple things that stood out to you. Based on screening, children may receive a comprehensive developmental evaluation, and that's most commonly by a developmental psychologist or a team. OT most commonly does not get involved prior to this. OT is most commonly involved either in the evaluation process or after a diagnosis is given, as we move toward intervention. Autism spectrum, and OT, we've talked about this before, cannot independently diagnose autism, but may be part of diagnostic teams. I also want to note that autism spectrum disorder, as it's defined in the DSM-5, now includes some things that were defined separately in the 4 and the 3. So these include autistic disorder, PDD-NOS, which stands for pervasive developmental delay not otherwise specified, or Asperger's syndrome. The guidance when the DSM-5 came out in 2013, I think it was 2013, was if someone already had a diagnosis of autistic disorder or Asperger's syndrome that was working for them, there was no need to reevaluate. But the diagnoses given once the DSM-5 was in effect would be under the category or under the diagnostic label of autism spectrum disorder. You will meet people who have a diagnosis of, there were also several other rarer conditions that were collapsed under autism spectrum disorder. You may meet people who strongly identify with, say, Asperger's syndrome, and that's totally fine. That can be a strong identity for folks. It's not a label that people are continuing to receive, though. So when we talk about social communication, which is one of those two big categories, right? The diagnostic indicators would be persistent deficits in social communication and social interaction across multiple contexts, which manifests by the following, either currently or by history. And they say by history because adults have often learned to mask a lot of their symptoms, but may report, or their caregivers may report earlier indicators. So this looks like deficits in social emotional reciprocity, which may range from abnormal social approach, failure of normal back and forth conversation. Back and forth conversation can be a big indicator. Reduced sharing of interests, of emotions, or of affect. Failure to initiate or respond to social interactions. Deficits in nonverbal communicative behaviors that are used for social interaction, things like poorly integrated verbal and nonverbal communication, unusual eye contact or body language, challenges understanding the use of gestures. We may see reduced facial expressions or just total lack of nonverbal communication. We may also see we would also expect to see deficits in developing, maintaining, and understanding relationships, ranging from difficulties adjusting behavior to suit various social contexts, to difficulties in sharing imaginative play. Imaginative play is particularly indicative, or in making friends, or absence of visible interest in peers. I do want to point out most people with autism want relationships and friends and social engagement. That may look unusual, or they may not be sure how to engage. And so it's more the interest that we can see that we're looking for. Restricted and repetitive behavior diagnostic criteria includes restricted and repetitive patterns of behavior, interests, or activities as manifested by at least 2 of the following. So we must see 2 of the following in order to make the diagnosis, either currently or by history. And the examples given are meant to be illustrative, not exhaustive, so they don't cover everything. Stereotyped or repetitive motor movements, use of objects or speech. So that would be the repetitive behavior piece. That might look like repeated motor movements, like hand flapping, lining up toys, flipping objects, spinning things, echolalia, repeating idiosyncratic phrases. It might look like insistence on sameness, inflexible adherence to routines or ritualized patterns of verbal or nonverbal behavior. So extreme distress at small changes, difficulty with transitions. We see this a lot in classrooms. Rigid thinking patterns, sort of ritualized social engagement, or the need to take the same route or eat the same food every day. We talked about this in our feeding lecture. Highly restricted, fixated interests that are abnormal in intensity or focus. So a very strong attachment to or preoccupation with unusual objects, or an excessively circumscribed or perseverative interest. This can, in adulthood, become a strength when you're just very, very good at something you're very interested in. But it can be a challenge to transition away from that thing. Hyper or hyporeactivity to sensory input. This should sound familiar from learning about the sensory profile. Unusual interests in sensory aspects of the environment. That can look like indifference to pain or temperature. Adverse response to specific sounds or textures. Excessively smelling and touching objects. Visual fascination with lights or movement. There are some other components to making a diagnosis. One is that symptoms must be present in the early developmental period. They may not become fully manifest until social demands exceed the limited capacities. So we think about what's expected in terms of a back and forth conversation with a 12-year-old. That looks very different from a toddler, right? And that may be where it becomes evident that someone is struggling with back and forth conversation. These may also be masked by learned strategies in later life. So as I mentioned, some adults are very good at memorizing social rules and masking a lot of this. And that's why we look at sort of earlier reports. Symptoms must cause clinically significant impairment in social, occupational, or other important areas of current functioning. And these disturbances must not be better explained by other diagnoses, like intellectual disability or global developmental delay. And so there's a specific protocol for diagnosing autism in the presence of, say, intellectual disability. And that's one of the most frequent comorbid diagnoses with autism. It's not uncommon. But to make that diagnosis, you're looking for social communication that's below that expected for the general developmental level. So it's that sort of discrepancy that would be indicative of autism. The DSM-5 also introduced severity levels. Level 3 is requiring very substantial support. So severe deficits in verbal and nonverbal communication and functioning, and severe inflexibility of behavior, extreme difficulty coping with change, markedly interfering with functioning in all spheres. And that could look like, say, someone who uses very few words. This is straight from the DSM-5. Who rarely initiates interaction, and when they do, it's to get some basic needs met. And they respond only to very direct social approaches. Level 2 is requiring substantial support. So we're still seeing marked deficits in verbal and nonverbal communication, and social impairments that are apparent even with supports in place. That's kind of the big difference between level 2 and level 1. We're also still seeing inflexibility of behavior, difficulty coping with change, frequently enough to be obvious to the casual observer and interfere with functioning in a variety of contexts. So that might look like somebody who speaks in simple sentences, whose interaction is limited to narrow special interests, and who has markedly unusual nonverbal communication. And finally, level 1 is requiring support, where without supports in place, deficits in social communication may cause noticeable impairments, but when the supports are present, we may not see that. Difficulty initiating social interaction, clear examples of atypical or unsuccessful response to social overtures of others. Inflexibility of behavior causes significant interference with functioning in one or more contexts. And we're still going to see difficulty switching between activities, problems of organization, and planning. So that could look like someone who speaks in full sentences and engages in communication, but to and fro conversation with others can be a challenge. And attempts to make friends may look unusual or be unsuccessful. So we're going to talk very briefly about statistics and prevalence. Autism is most commonly diagnosed between ages 3 and 10. It is 4 times more common in boys. And the population prevalence is somewhere between 1 in 59 and 1 in 54, depending on which data you are relying on. So that's 1 in 59 children will receive a diagnosis of autism. We're going to talk briefly through autism and occupations. When it comes to play, children with autism have noted differences in play, partly because of all of those symptoms we've already talked through. This can look like a preoccupation with and unusual use of objects, sensory exploration of objects beyond expected ages of sensory motor and exploratory play. Sensory seeking is common in play at home, school, and in outdoor spaces. We'll see more repetitive and less varied functional play. So using objects as intended, but in repetitive ways. Difficulty generating flexible and novel play ideas, and decreased likelihood of engaging in pretend play or pretend play for shorter durations. It is important to note that children with autism can still pretend and play, but may need more scaffolding and prompting from adults in order to do so. Sleep. Disordered sleep is common in 40 to 73% of children with autism spectrum disorder. This looks like difficulty falling asleep and challenges with bedtime routines, difficulty staying asleep, waking early, and parental sleep disruption. Sleep is important for children with autism and an important area of intervention. And we will pause here and resume in the next recording.